inshallah. Okay, my lecture is about case-based the case about extensive coronary calcification. Hit it hard, or it will hit you back. Okay, my case is a 70-year-old male patient. He's not diabetic or hypertensive, not known ischemic before. He was diagnosed with mucosa-associated lymphoid tissue, MALT, gastric non-Hodgkin lymphoma from 5 years. He received a course of rituximab, which is a targeted monoclonal antibody cancer chemotherapy, followed by 20 sessions of radiotherapy. The patient was declared cancer-free after several checkups. He presented like 2 years ago with dyspnea grade 3 to 4. His blood pressure was quite stable. He had non-specific ECG changes. The echo showed a picture of dilated cardiomyopathy according to the description of the echo, with global LV hypokinesia, an ejection fraction of 32%, severe mitral regurg, severe tricuspid regurg, and a pulmonary artery systolic pressure of 65 millimeter mercury. So the diagnosis by that time was probably a case of cancer therapy-related cardiac dysfunction. So he received the full anti-failure measures with torzoretic, iplerenone, carvedilol, valsartan, and procorolen. 3 months later, the symptoms improved dramatically, with an ejection fraction increasing to 45%. 6 months later, the ejection fraction increased to 52%, and the patient remained symptom-free on regular treatment. However, 1 year later, the patient started to complain again of dyspnea with exertional chest discomfort. The echo showed a decline in the ejection fraction again to 42%. And so, because the likelihood of coronary artery disease was quite low, looking to the background of the patient, so we probably ordered a multi-slice CT first requested, and this was the CT angiography of the patient, showed a total calcium score of 3,736. The RCA alone was 2,500 and more. So we ordered a diagnostic coronary angiography. It revealed extensive coronary calcification, particularly the LAD, as well as the circumflex. Same in the caudal view. This was the LAO-caudal view, and also the cranial view. So it's a tram-like calcification going through the left coronary system. This is the cranial view, and this is the right coronary artery. So the heart team discussion was held. Patient was found to be of high surgical risk because of the prior medical history, as well as the heavily calcified coronary targets. The decision was taken to proceed with PCI after discussing with the patient and preparing our tools. So the problem with calcium is actually two important issues: the failure to cross the lesion and also the underexpansion of the stents. A meta-analysis of 13 studies of more than 66,000 patients showed that the target lesion revascularization was 47% higher with calcific lesions, and stent thrombosis was 63% more in cases of calcification. Calcium detection among angio, IVUS, and OCT, of course, the sensitivity of calcium detection with angiography is quite low compared to OCT or IVUS, and what can be detected by IVUS and OCT is actually much more than what can be appreciated by angiography alone. So the angiographic score of calcium, whenever we entail angiographic calcium, we score the calcium by IVUS. Whenever we have an angiographic calcification, we just do an IVUS, and according to the IVUS score, we can consider or not atherectomy. So the important items to be considered is a calcium arc that is more than 270 degrees of more than 5 millimeter length, or a complete 360 degrees calcium arc, a calcific nodule, and a vessel diameter that is less than 3.5 millimeter. Every one of this takes a point, a score, of 1, so that a score of 2 or more is considered for atherectomy. The goals of the therapy, of course, is to cross the lesion and is to modify the lesion by reducing the calcium volume or fracturing the calcium in order to maximize the luminal gain. This could be done by a balloon-based strategy using scoring balloon, cutting balloons, or ultra-high pressure balloons, or a non-balloon-based strategy using atherectomy, whether rotational or orbital, intravascular lithotripsy, or laser atherectomy. So how to assess calcified lesions: assess the calcium distribution, thickness, the length, the vessel size to choose the appropriate tools. We assess the effect of calcium modification prior to stenting, and then we assess the result of stenting, expansion, apposition, and edges. So we have 3 stops, one before calcium modification, one after calcium modification, and the other after the stenting. Of course, if it's a balloon non-crossable lesion, we have to start with rotablation. But if it's balloon crossable, then we can introduce intravascular imaging, and we assess the calcium score by IVUS. And if there is optimal balloon expansion, that's well and good. If not, then we may opt to intravascular lithotripsy. The final result is that we need a proper stent implantation and expansion. So this was the PCI procedure. We tried to cross the IVUS. It was impossible to cross it. You can appreciate how that the IVUS got stuck into the calcium, and when we dragged it back, it actually caused deep intubation of the guiding catheter. Also, trying to cross the Corsair in order to switch to the rota wire was quite difficult, and also it resulted in the same problem. The Corsair got stuck into the calcium, also causing deep intubation on dragging it back. So we made a balloon dilatation with a 1.5 Maverick balloon, and it crossed. We made some cracking of this small calcium, the small narrow coronary passage, and then we struggled to advance the microcatheter. Still, it got stuck at this point. So we just, you can see how we are struggling with to advance the microcatheter. And so we just impacted the microcatheter as deep as it can go, and we advanced the rota wire, and it went smoothly. Rotablation was done several runs with 1.5 millimeter burr. Further rotablation runs. So tough calcium. And finally, a control angio to check, and the first IVUS run was conducted. Well, the IVUS showed that the distal target vessel diameter was about 3.25, 3.2 millimeter. There was a lot of calcium, concentric calcium. The proximal part, this ectatic part, was like 4.4 millimeter. And these are the calcium cracks that we have created with the first rota run. We had a 360 degrees arc of calcium. We had calcific nodules in several frames. So we were convinced that we have cracked the calcium quite well. So we went with high pressure balloons, 3.0 balloon, inflated at high pressures. We can appreciate the waist that has been now inflated properly. Then a 3.5 millimeter balloon, also inflated to an optimal expansion. The control angio, we made sure everything is fine. And then we did another IVUS run after the NC balloon inflations. The calcium was well cracked, as we can see and appreciate, with optimal lumen gain. And so we thought that we are quite ready now to place our stents. We stented from distal to proximal, 3.5 millimeter drug-eluting stent, followed by a 4.0 millimeter stent proximally, because the distal reference diameter was 3.25, as we have mentioned. And there is a part that is more than 4, but we opted to go for a 4.0 stent, and then we post-dilated with a 4.5 millimeter NC balloon, and this was the control angio. And when we went for the post-stenting IVUS, unfortunately, the IVUS malfunctioned. So we just thought it's okay, let's take the final runs. We did the LCX as well. It was not that calcific actually. Just pre-dilatation, a 2.75 millimeter stent, optimally inflated, the control angio, post-dilatation with a 3.0 NC balloon in the CX, and this was the final results. So the key message is calcified coronary lesions increase the procedural complications and implicate long-term outcomes after PCI. IVUS is mandatory for quantifying calcium burden and guiding treatment. Always be ready with upfront tools for adequate lesion preparation and to ensure adequate stent expansion. And patients with prior chemo and radiotherapy should always be suspected for heavy calcium heavy burden coronary artery disease, even in the absence of traditional risk factors. Always a good team is behind success. Thank you very much.
A pleasure to be here to speak with you. I've really enjoyed Egypt, as you can probably see from that picture, and spent an entire week here before the meeting. Yeah, does this? Sure. Or I can use this, right?
Yeah, whatever you like.
Okay, and then, yeah. Okay, and that works, so that's fantastic. So, I offered to give a lecture on the technical how I do a DK crush, but that wasn't actually requested. So this was a lecture I was asked to provide, and I think it's a reasonable topic. When do we choose provisional? When do we choose upfront two-stent technique for the left main? True bifurcation. So my considerations for left main PCI, and as you can see, some of them work, some of them don't. There are 3 different left main bifurcations, all of them kind of complex. One of them is a trifurcation. And so I think before you tackle left mains, you should be pretty experienced. Especially complex left mains. I think that's obvious. I think a beginning operator should at the very least get some help from a more experienced colleague, because many things can go wrong, and that would be the issue. I think the facilities and equipment are important. When we are dealing with the left main, we need some kind of mechanical support around, I think. A balloon pump is just going to work well in most situations, and I think that's probably what's available for most of you. And that's what I would use emergently. Occasionally I would go to an Impella as well. And then I can't overemphasize the importance of intravascular imaging, especially in the left main. Half of left mains are calcified, and they're going to be heavily calcified, and you're not going to see that calcium by coronary imaging in many of those cases, as was already eloquently shown. So intravascular imaging, a lot of these patients have chronic kidney disease, so IVUS versus OCT. I tend to go to IVUS. Occasionally I'll use OCT if patients have normal renal function. And then, of course, you can't really assess the ostium of the left main with OCT particularly well. So IVUS tends to be my most predominant modality to assess for imaging of the plaque. And then finally, as was already explained, plaque modification. I don't think I need to belabor that point. That was really well done. And generally with ROTA or Rotatripsy is something we often use, which is a combination of ROTA. If you have that uncrossable lesion, you need to cross it with the ROTA. And then if it's a thick circumferential calcific plaque, no matter what you go to, even if you go to 2 millimeters, 2.25 millimeters, which is the maximum for ROTA, you may still need to go with lithotripsy if you have a 4+ millimeter vessel and your plaque hasn't yielded. The anatomy is important. Obviously, we're talking about true bifurcations, but even non-true bifurcation lesions need to be treated carefully. What's lesion complexity be? What's the angulation? What's the calcium content as we see? Where is that calcium? Is it concentric? Is it eccentric? The bifurcation angle in the left main tends to be less important because they tend to be around 90 degrees. They tend to be T bifurcations for the most part, not all of them, but majority of them tend to be T bifurcations, so that's not a major consideration. And finally, the LV function. That relates to the mechanical support. When do you actually use mechanical support? And we have a public healthcare system in Canada, so and the Impella is actually not funded, so the hospital has to raise money for the Impella, and I know it's not available here. I'm sure for probably similar reasons. Plus, actually, to be honest, there's no trial evidence of where it actually really works. We're not guided by clinical trials. But in general, if I have complex left main anatomy and an EF somewhere in the less than 35 to maybe 20 range, I'll usually start with a balloon pump. I will always put in a PA catheter, and if the LVDP is high, I'm more likely then to insert LV support. If the LVDP is low, if the wedge pressure, the PA pressures are low, I may choose not to, but I will also always put in a small sheath on the opposite side, like a 5 French, to make sure that I'm not trying to gain access if the patient is crashing. That would be the worst time to do it. So it costs little to put in a 5 French sheath on the side that you're not using. I use the radial quite a bit. I use, in many patients, I'll use 7 French radial. Many patients can actually take that, and if I'm doing dual access, then I'll use radial femoral if there's a CTO involved, for example. So LV function is important. So I mentioned bifurcation angle, but here's a new concept that I'd like to introduce, and that's the dynamic angle of the bifurcation. This was published recently by Wang and colleagues, and what they did, if this ever starts moving, okay, what they did is they looked at 194 patients with ISR versus not ISR. What they found is that there was a greater dynamic swing, if you wish, in the bifurcation from diastole to systole. And to simply show you their, this was their the bifurcation angle, the proximal left main to circumflex or to bifurcation angle is what they were measuring. There's also distal bifurcation angle, which they looked at as well. And this isn't the first time this was looked at. So this was published in 21 by Antonio Colombo's group, Watanabe, lead author. And they looked at the distal bifurcation angle. And what they found, they measured the dynamic nature of the angle, so how much it changed from systole diastole. And they found that the median was 7.2 degrees. And what you'll see is a remarkable increase in adverse events if the bifurcation angle change was actually greater than that median. So this is something I had not really considered in this, and I think it's something we need to look at, study more, and actually consider when we're choosing 2-stent procedures for the left main. It's probably a minority of patients, but it may impact on the outcome very much. So getting back to Wang's study, if I can help myself here again. So Wang found pretty much the same thing, that if in the patients who had a bifurcation angle change of greater than 16 degrees, this was a proximal bifurcation angle from left main to circ. Look at the percentage of patients with who had proportions of these particular angles, and what they found also was that you might think that in fact if you straighten it out so that it actually angulates less from systole diastole after you stent, It's in fact the opposite. The more you restrict that change, the greater your restenosis rate. So if you really make that angle stiff, in other words, there was a more of a dynamic nature to it, and now you've restricted that, there's actually a cost in terms of restenosis, in terms of adverse events. I won't talk too much about intravascular imaging because that was covered really well earlier in the day and also in the previous lecture. But specific to left mains, there was an excellent study which really, a large registry done by the BSIS group, which in fact showed marked improvement or association with much better outcome when intravascular imaging was used versus when only angiographic imaging was used. So again, I think it shows the importance of us using intravascular imaging in that setting. Why is that the case? Well, it's this. This is just an example. This is the Syntax trial and 10-year analysis of the Syntax trial based on how calcified the vessels were. So if there was at least one heavily calcified lesion found, and these are all the patients, so the more calcified were older patients. I won't go through all of the baseline characteristics, and I think you can see that well. But this is patients without heavily calcified lesions, and this is patients with heavily calcified lesions, 3-vessel disease and left main disease. So those with left main disease had double the adverse event rate, in fact mortality, not just adverse event rate, but mortality at 10 years compared to those who did not have a heavily calcified lesion. And you might think that it's going to be better with surgery if you have heavily calcified lesions. In fact, that was not the case. The patients with heavily calcified lesions who underwent CABG had the worst outcome. So that's an important observation, I think, for us. So let's look at how we choose whether to go 1 stent versus 2 stent. And I think I'm running out of time. This was published by Tanvir Rab a few years ago, and it's with Xiaoliang Chen. This was after they actually introduced the context of complex versus simple bifurcation lesions. So if we have a simple lesion, which is less than 70 in the left main or 90% in the non-left main, so 70% in the left main, lesion less than 10, easy side branch axis. That's the other important consideration. If you think your side branch axis is going to be difficult, maybe a 2-stent technique in an important side branch may be the way to go. If the answer is no, 2 stents, they recommended inverted culotte. I'm not sure why, because this was Xiaoliang Chen. And if it was yes, then you would go with provisional. And if there's compromise of flow, FFR less than 0.8 or less than TIMI3 flow, then you would add a second stent in a provisional fashion. T-tap. I actually like reverse crush, which gives you the best coverage of the ostium. If it's a complex lesion, then you would go to 2 stents first. Always use IVUS OCT imaging, which what they highly recommend. What's the data for all of this? Because they did recommend the DK Crush. This was DK Crush 3, the first comparison actually between 2 stent techniques in relatively complex lesions, DK Crush versus culotte. And what they found was a doubling essentially of restenosis in the culotte group, and marked difference in outcome as well at 1 year, but also going out to 3 years, as you can see. So DK Crush was better than culotte, but these are DK Crush experts. So that's my only caveat to that, is that they will do the DK Crush extremely well, and I've actually done cases in their labs, and they are truly experts at it. Let's go back next to exploring 2 stent versus provisional, and that's DK Crush 5. And I won't spend too much time on this. It was a well-run randomized trial. Again, showing better outcome, target lesion failure doubled with the simple approach. This led to the definition study, which actually defined what complex and simple was. And here it is. So the definition study was a registry, large registry, also a validation cohort. And these were the criteria to define a complex lesion. So if you had a distal left main bifurcation, stenosis greater than 70, and a side branch lesion length of greater than 10 or greater, non-left main, stenosis of greater than 90%, and a side branch lesion length, again, greater than 10. And these are the minor criteria. So you needed 2 of any of these plus 1 of these, and that would define a complex lesion. From this, they went to the definition 2 study where they enrolled complex patients. This is not all left main, but there were a significant proportion, up to a third of left main patients. This just shows you quickly the complexity. Moderate to severe calcification in 40%. Lesion length in this side branch, 20. I haven't seen another study that had a side branch length like this. And a high syntax score. Culotte, DK crush was used in the majority of them, but not all of them. And these were their outcomes. These were their event rates, TLR, target lesion failure. As you can see, a doubling in the simple compared to the complex, i.e. mostly DK crush. And so they then took this to look at the data in DK crush 5, which was the left main study, of course, and looked at simple lesions versus complex lesions. The complex lesions, there's a huge difference and a statistically significant difference in spite of the fact that it's a relatively small number of patients. They also observed that there was a non-significant difference in the simple lesions, and so their recommendations were we should use DK crush in complex lesions. However, this you can see is trending, and it's simply underpowered, and what you would need is a sample size of 407 per group for this to be statistically significant. And actually they're doing a study just like this right now, about 800 patients, called DK crush 9, where they're looking at simple patients comparing DK crush versus simple. EBC main, very different study, showed no benefit to 2-stent technique, only 5%. Are we running out of time? Okay, I'm sorry. Let me just come to the conclusions then. This is a big difference between the studies. Side branch lesion length in the DK crush, complex lesions, EBC main, simple lesions. So maybe simple left main bifurcation lesions are better treated with provisional approach, except that for this observation from my perspective. So in summary, we have clear guidance from randomized trials regarding the patient subset that benefits from a planned 2-stent approach, irrespective of the strategy utilized. Meticulous technique is required to ensure best patient outcome, i.e. optimal lesion preparation, proximal optimization technique at various steps in the DK crush, if that's what you used. Left main PCI should be performed in facilities equipped to deal with complex anatomy and the complex patient. The DK crush provides the best coverage of the side branch ostium and best geometry of any technique, is the only technique to have randomized trial superiority evidence against the provisional approach and Culotte in left main PCI. DK crush data are all collected by one group, and I think they need validation by others, and we're actually just launching a pilot or a vanguard study to see if we can do this in elsewhere other than in Eastern Asia and China. Can the rest of us do this as well? And the Axis one is our study, and so I'd like to thank you for your attention, and sorry I went a little bit over time. And that's another one of my pictures. So.
That was a really fantastic, elegant presentation.
Thank you.
Of treatment participation. If I may ask, I mean, obviously you sound like you are doing proper DK crush. What's the difference in your experience between DK crush and nano?
So the problem, to my mind, the problem with the nano crush, you can miss the ostium. It's very difficult. So nano versus mini versus DK. Mini is no different than a regular crush because you are basically crushing the entire stent, even though it might be 1-2 struts against the left main, against the ostium of the side branch. And so you have the same issue recrossing eventually through 3 stent layers. The nano crush would work, but I think there's more of a risk of missing the ostium with the nano crush. So that's why I think the true DK crush, and we have no data for nano crush, the true DK crush actually ensures complete coverage, providing also you do it well, providing you recross in the appropriate part of the ostium, etc. There's a question behind you. I don't know if we know that there's a stent like that, and I'm more, if I see a severe change in angulation, I would strongly consider not putting a second stent and maybe treating with a drug-coated balloon, providing I get a good balloon result.
I have two comments. Actually, with the support devices, there are all negative trials.
Yes.
And even the Euroshock, which was our platform, because we are using
Yeah.
ECMO.
Yeah.
ECMO was a failure.
Mm-hmm.
Intra-aortic balloon is a failure.
Aortic balloon pump is not entirely a failure in complex PCI.
I mean,
It's not
it didn't
actually.
show mortality benefit.
It did at 5 years.
Yeah,
At 5 years it did. So,
So,
all I can say, so let's talk about the balloon pump in BSIS 1.
Yeah.
In BSIS 1, there was a marked reduction in intra-cath lab events, right? So it was like a 10% versus 1%. If you looked at the Kaplan-Meier curve at, I think it was 6 months, was their primary endpoint. There was a separation of curves, but the study was underpowered. And so how do you improve power? You either get more patients or you extend the observation time. So taking out to 5 years, the curves continued to separate, and it was actually positive at 5 years. So I think this is not at all inconsistent.
Well, our impression is that it will make you feel better, more.
I don't think so. I think it brings down the wedge pressure, it improves the hemodynamics during the procedure. I think it makes the patient feel better as well, the appropriate patients. I'm sorry, I interrupted.
What's the definition of a simple bifurcation?
The simple bifurcation is the one that doesn't,
Beyond 5 millimeters.
yeah,
Then why to do 2 stents? I mean, there's no need for 2 stents from the start.
yeah, that's a simple bifurcation.
So,
I agree.
So how
I
can
agree.
we compare simple and DK crush in the same category?
Oh, because in the DK crush, they did all comer left mains. And it was only after they published DK crush 5 that they developed this concept of complex versus simple bifurcations. And it was in retrospect that they did that analysis. But even when you look at the simple, there was a p-value of 0.08 and a reduction of 15 to 8%, I believe. And so even that was trending, and that's why they're now doing a larger trial. Hopefully that's powered adequately in simple left main bifurcations.
Thank you very much.
Thank you. Thank you. Pleasure to be here.
Dr. Hassani? Yes. Dr. Hassani is going to give us a lecture or presentation of left main imaging.
دكتور طارق ولا بسم الله الرحمن الرحيم. Certainly it's my pleasure to be with you today. I will be talking about imaging guided left main interventions. So why imaging is particularly important in left main interventions? Because with the increasing utilization of intravascular imaging and left main bifurcation complex, the whole complex of left main bi or trifurcating into its daughter vessels, the isolated lesions are mostly an angiographic deception. This is why, because from the seminal paper from the European Bifurcation Club, if we are looking towards our left-hand side, this is the angiographic classification for the Medina, and if we are looking from the down bottoms, if you are seeing angiographically that this is a Medina 000, no vessels are affected here. As a matter of fact, almost 65% from them have Medina 111 plaque configuration through the left main complex. If you looked at what we may perceive as an isolated circumflex osteal disease, it's almost 90% of them have a 3-vessel affection, distal left main, ostial LAD, and ostial circumflex. Same, but probably in the range of 80% 3-vessel disease if we are seeing only an isolated LAD, and if you are seeing it as just distal left main with 3 ostia, as a matter of fact, it's almost 90% with 3-vessel affection. Through the multifocality of left main disease, plaque formation is the rule. Why this is particularly in the left main complex? Because it is short, it is early bifurcating or trifurcating with the flow divider directly subjected to the aortic pressure. And when the flow, according to the dynamics, diverges, the sites for the carina or the contralateral sites of the bifurcation away from the flow divider are subjected to low shear stress. That low shear stress actually causes degradation of the nitric oxide and prostaglandins, upregulation of the endothelins, upregulation of the LDL uptake and oxidation, and hence promotes the inflammation, vascular smooth muscle proliferation, plaque growth, fibrous cap degradation, and all of these, as a matter of fact, causes more and more for plaque vulnerability. Also, because it is short and early bifurcating in many instances, we lack to see a part of the left main that we judge as a healthy reference segment, so we can easily miss a tubular narrowing that is diffusely affecting the left main. What modalities for coronary imaging do we have in order to solve this dilemma? We have the optical coherence tomography, the coronary angioscopy, the IVUS, the CTCA, all besides the conventional invasive angiography. And as a matter of fact, it's very difficult to say that one of these modalities is the superhero that can replace others, because I have to surprise you that all of these images are taken from the same patient, from the same lesion, but everyone is looking at a different aspect of the plaque formation. But for my title, because we are looking now at what imaging modalities can guide intervention, practically IVUS and OCT are the tools of choice. Probably because OCT usually requires clearing of the blood from the medium by a transparent fluid that is often contrast, and because it lacks the good practicality to see ortho-osteal assessments, IVUS has dominated over OCT in left main interventions guidance, despite all the other advantages of OCT. And hence, from the pooled recommendations from the 2021 ACC/HA SCI and the European Society Cardiology 2018, we will find that in the bottom of the recommendations that were driven specifically for left main interventions, that use of intravascular imaging, specifically IVUS from both sides to guide left main interventions, are graded as class 2A. It is reasonable to use it. And again, why, if we are looking from the perspective of the outcomes of our procedure and the patient's prognosis? Because in this study, they looked at the comparison of in-stent failures or in-stent restenosis, the target lesion failure, and particularly the way comparing between the 2 stents upfront and the 1 stent results. Looking at the Achilles heel, which is the future ISR or target lesion failure, correlating it with the underexpansion and malopposition of the stents. When we are using 1 stent strategy in a provisional technique, as a matter of fact, the Achilles heel is minimally found, despite when we say that I'm using 2 stents in order to maximize the coverage and the optimization of the left main bifurcation complex, there are too many spots that are subjected to stents underexpansion and hence to future ISR. And from there, we got the recommendation that you should not leave your patient with a minimal stent area less than 8 in the left main shaft, less than 7 in the polygon of confluence, less than 6 in the ostial paraostium of the LAD, and 5 for the circumflex. And I'm privileged to have Professor Vladimir covered all of this chart, but I am now very concerned with that box that is not a step through the process. It is not related to any arrows. It comes as a stand-alone. We have to use intravascular imaging, either IVUS or OCT, is very strongly recommended to optimize my results in left main intervention. I will run through three quick examples to show what I'm talking about. This was an 82 years male patient with a lot of comorbidities. He was presenting with non-ST elevation, myocardial infarction, apprehensive, and severe agony. The patient was very distressed, not cooperative on the table. He has preserved ejection fraction, and he has diffusely diseased CTO at multiple spots in the right coronary artery, and hence his left main is super important to him. And where do you judge this aneurysm to be? In the areocaudal, it seems related to one of those two rami. In the epicranial, probably I can judge that it is very away from the circumflex confidently, and it is related to the LAD, while in the spider view, I am very inclined to say that it is very away from the LAD and it is lying over one of the rami or the circumflex. Am I right? Okay. Quickly, we wired both important vessels, the LAD and the circumflex. I paved the way for the IVUS with predilation with a 320 balloon, and this was the IVUS. Let me go with you quickly with a manual run, because the first bookmark, this is the calcification in the proximal to mid LAD with a lot of concentric 360 calcifications. But as we move towards the proximal ostial LAD, we will find that the aneurysm, and now we do not have any wires beside the IVUS probe, the volcano IVUS probe. As we go more proximal, this aneurysm ends into a well-formed vessel, and then the wire comes and approach. This is the circumflex wire into the left main. So IVUS answered the question very confidently. This aneurysm is nothing from the left main complex. It is from the very proximal LAD. And hence, this answer actually impacted my strategy in solving the problem very well. Now, we went for 2 overlapping drug-eluting stents from the aorto-ostium into the LAD with well coverage to the aneurysm. And with IVUS guidance, we optimized the whole thing and have this final result pretty acceptable from before and after in the epicranial and in the caudal views. Actually, one of other stuff to monitor that the heart rate of the patient got a lot more convenient after the procedure. Because I'm running out of time, I will skip the second example and go directly to the third. This was a lady. Her right coronary artery, as a matter of fact, had 3 focal lesions from proximal to distal. But now we have a subtotal stenosis in the proximal. In the distal left main, the circumflex is diffusely diseased and a tiny vessel, and calcification in the very proximal LAD, then a CTO in almost dual LAD physiology in the diagonal, the only major biggish diagonal. It was a tough procedure, but after securing the left main ostium while I am introducing the second stent, actually it slipped from the balloon, and I had my balloon floating and the stent partially slipped from it because it got stuck into the calcium in the proximal LAD, and when I'm trying to put it, the balloon got out. This was a 2.5 balloon, and there was no other solution except to deploy it inside 2 piecemeal with a 1.2 and then by a 2 PTCA balloons. And finally, after solving the whole dilemma, I had this intravascular imaging. And despite OCD is not the modality of choice, but now my biggest concern was stent apposition. So I had to go to the modality that shows me better the stent apposition. Now, those overlying metals are the struts that are floating. And these are the 2 wires that are one underneath is going away into the diagonal. while this one, presuming, is the LAD wire. This is a luminal 3D navigation. And according to the areas of the flowing struts, we optimized the procedure, the whole thing, to have this final result with the left main LAD, the part with the crushed metal or the crowded metal and the diagonal branches. So my key message is that angiography alone can be misleading in very complex 3D anatomies. This is particularly important in left main PCIs. Better understanding of the anatomical complexity can always guide to the most reasonable, simple, and safe solutions. In nowadays PCI, intravascular imaging in left main interventions became a necessity. It held significant impact on procedural outcomes and patient prognosis, and presentation with acute MI is not an
Okay, before, this is our recommendation of the bifurcation club, is before you do a bifurcation, then you should have these 3 A's before you say bifurcation. And these 3 A's to assess, anticipate, and align. So the 3 diameters should be there, the plaque length and distribution, and the bifurcation angle, and the side branch ostium. And then you start your plan. And to have a true bifurcation, as was said before, then you should, the definition of true bifurcation is you have more than 50% lesion in both main and side branch. The burden of severe atheroma extends beyond 5 millimeters from the side branch ostium, and it should be a large side branch, so it's affecting a large part of viable myocardium. So it should be 2 millimeters or more. That's the definition of a true bifurcation. You all know, of course, this, I will not go through it, but this is important, the 3 diameters, because D1 is not essentially equal to D2. It's the maybe you can say 2/3 of 0.7 of the sum of D1, D2, and D3. And as was said elegantly by Dr. Ahmed, that the shear stress is very high at the carina, so nothing happens in the carina. It's always on the sides, not on the carina itself. The angle is important because if it's an acute angle, then covering the ostium will be more difficult. The carina shift will be more likely, but side branch wiring is much easier. While with this kind of angulation, it will be very difficult to angulate. Sometimes you are obliged to put 2 stents because of this angulation. But it's less likely to have a carina shift, and it's very difficult to, it's very simple to cover the branch. When we discussed the culotte technique was very favored by the British, by the way, at the very start, and they were promoting this culotte technique until this kind of, the one you showed, that DK crush is better than culotte in many ways. But there are some prerequisites for a culotte technique, is that to have equal size of the side branch and the main branch, or at least 0.25 or 0.5 only difference, because if you use culotte for every case, you will have a problem. These are the steps for the culotte. You wire 2 branches, and then you dilate the main branch, and then the side branch pre-dilatation. You put the stent first in the side branch, deploy it, and then rewire the main branch and dilate the struts of the side branch, then stent the main branch, and you end up with casing after that. Sometimes you do pot, but you don't need really pot in culotte technique, unlike the DK crush. And the DK crush is more and more getting favorable now. And this is a case of a 50-year-old male, smoker, hypertensive, with diabetic and dyslipidemic. And he's presented with an advanced stage of accelerating angina. And he had ST depression and T-wave inversion from V2 to V6. And his ejection fraction was 45% in the LAD territory. This is his coronary angio. Maybe this view is not that favorable, but you can see that I don't know if you see it or not, the LAD is nearly totally occluded, and the side branch is affected, the diagonal, which is rather big. So, don't know if you can see the distal LED feels very late, you see. I cannot stop it, but if you have the... Then the strategy here was a DK crush. And this is an animation for the DK crush. You wire the two branches, and then stent the side branch, and then with the balloon in the main branch, and then after you stent the side branch, you crush the side branch stent with the balloon in the main branch, and then rewire the side branch, and then do the first kiss. This is the first kiss of the DK crush. And after the first kiss, then you put the stent in the main branch. It's a little bit slow, but it will come. Then you put the stent in the main branch after removing the wire. Some operators don't remove the wire, and it proved, contrary to what we're believing first, that hydrophilic wires are more resilient and they can really be left alone. And this is the crush of the crushing of the side branch with the stent, and then rewiring and finishing up with kissing balloon. And what's missing in this animation is the final pot, because the final pot is very important. Okay, so this is the case I've shown you before. This is the wire. The wire crossed both the LAG and the diagonal branch. Then we dilated the LAG because it's nearly totally occluded. So we dilated first the LAG with the balloon, and the balloon here. And then after dilatation of the LAG, we put the stent in the diagonal branch. I'm trying to move rapid, I don't know if it's moving. This is the stent in the diagonal branch with the balloon in the main branch. And after you stent with some protrusion into the main branch, you crush with the balloon, and then you remove everything and put the wire. This is the result of the side branch, and then you do the first kiss. And then you stent the main branch with removing everything. We don't remove it anymore now, but sometimes you get some fears and you remove it. It's not a big deal. And then you end up with after crossing with the recrossing of the wire, you end up with the kissing, and then the final pot. This is the kissing, and then the final pot. What's important here, Adasha, I want to show you the pot, because the pot should be at the distal edge of the bifurcation, not at the proximal edge, so that you will have a proper pot. So don't just put your balloon above the bifurcation. It's just at the distal edge of the bifurcation, the distal edge of the balloon. And this is the final result in the left main. I will give some notes on the nano crush because it was mentioned and I was ready for it. This is a 72 years old male with type 2 diabetes, hypertension, COPD, and ischemic heart disease. In 2019, he did PCI to the right coronary, posterolateral PGA, and OM2, and he's having chest pain. Coronary angio showed normal circumflex, and there was retrograde filling, you can see here, of the right coronary, and you can see this complex left LAG bifurcation with some aneurysmal dilatation at the ostium of the diagonal. And I'll show you now the steps of the DK crush, nano crush. This is a typical complex bifurcation lesion. This is his right coronary. There is total occlusion of the posterolateral branch with a stent on. I don't know if you can see it or not, but there was an stent. This was not done on the same sitting, so we'll just concentrate on the PCI to LAG bifurcation by nano crush technique. and we will leave the PCI for the right coronary on another stage. This is how to do it. You inflate the balloon in the main branch. You push back the stent until it's hitting the balloon inflated in the main branch, and you use the balloon in the main branch maybe 0.5 millimeter below the diameter of the main branch. And once you hit this balloon, then you have very minimal or nano protrusion of the stent, so you inflate the stent. The next step would be inflation of the pulling back the balloon and do a kissing, and then after you're doing the kissing, you put the second stent, and I'll show you here better maybe than the illustration. This is wiring of both. This is the balloon in the side branch and the balloon in the main branch. Then you keep the balloon in the main branch while inflated, and you pull back your stent until it hits, you can see here, it hits the balloon and the marker of the stent just a little bit inside the lumen, not totally inside the lumen, and then you pull back the balloon and do your kissing, the balloon of the stent, of course, and you do your kissing, and then you put the second stent, and this is what you see with the nano crush. The nano crush is much not easier, but it's much rapider. I mean, you don't waste much time in recrossing and recrossing again, but you have to do a pot finally, and as I told you, the pot should be at the distal edge of the stent. And this is the kissing, and this is the final result. So the key message from nano crush is that you don't care about the angles, which is important, whether it's a acute angle, right angle. It ensures minimal protrusion, not just protrusion, because sometimes you are not able to recross again in the second time. It's easy to perform and operator friendly because you don't do double kissing, but still we need further studies because we don't know the long term. What would be the long term would be another two strategies in the management of bifurcation, because the mini crush looks like this, but without kissing balloon. So my take-home message, Mr. Chairman, that you have to choose the best technique for each bifurcation according to the classification, site, and angle, mastering at least two techniques. And I advise DK crush and culotte. TAP is there. I mean, TAP is not really a technique. I don't call it a technique. It's a bailout for dissection. Know your tools and equipment, and don't start except if you have them all. You have the right balloon, have the right length of the stent. Follow the steps of the techniques as explained. Don't use your imagination. And any missing step will make life much more difficult for you, or even lead to failure, and even more difficult to the patient himself. Bifurcation stenting needs experience, skills, and proper bailout techniques. Final kissing is mandatory in any stenting